Good morning, everyone. We'll get started in another minute or so. All right, good morning, everyone. Welcome to October AIDS Clinical Conference. I am very pleased to introduce our speaker today, our very own Julie Dombrowski, who always gives an excellent talk. She is an associate professor of medicine here at the University of Washington and deputy director of public health, Seattle-King County HIV STD. Her research interests actually focus on improving HIV and STI clinical and public health services, particularly for vulnerable populations, not only here in the Seattle area, but all over the US. And she works as a primary care provider at the Madison Clinic as well as the Max Clinic. Thank you so much, Julie, for coming today to speak about what's new in STDs.
Great, thank you so much, Sharisha, and good morning, everybody. It's my pleasure to be here with you today to talk about STDs with a focus on what's new and what clinicians need to know. So 2 brief disclosures. I have participated in research funded by Hologic, and I am a member of the Treatment Guidelines Committee for CDC, so need to honor confidentiality for anything that has not yet been presented publicly. When Sharisha and Amber and the ACC organizers invited me to give this talk in January of 2020, the idea was that I would be discussing changes in the treatment guidelines because we thought that they would be published by now. But a lot has happened in the last 9 months, and at this point, the treatment guidelines won't come out until 2021. However, a lot of great science was presented at the recent STD Prevention Conference, and the guidelines changes have been clearly foreshadowed. So I do have some new information to share with you today. I've broken the talk into 4 sections, starting with a focus on treatment changes, going into the COVID-19 context, congenital syphilis, and finishing up with advances in prevention. I've tried to break things up with a few polls and quizzes and hope to bring you back in between those sections if I've lost your attention in the meantime. Well, any discussion of STDs needs to start with reminding us that prior to 2020 and prior to COVID-19, STDs had been surging for over 5 years in a row. And this largely reflects increases among men who have sex with men, but rates have also been increasing substantially among women and men who have sex with women, as reflected in the enormous increase in congenital syphilis that we've seen over the last 5 years, a devastating problem that we've not yet been able to turn around. And I'm not going to focus much on epidemiologic trends today in order to make room for clinical issues that need to be addressed, and because, like everything in 2020, a lot has changed. Okay, so let's bring up the first poll. In the 2019 CDC report, Antibiotic Resistance in the United States, Neisseria gonorrhea was ranked at which threat level, going from most to least concerning, and the decision criteria shown there. Thank you all for voting. It's great to see these coming in. And now slowing down. So Chris, let's go ahead and close the poll. Okay, great. So about half of people voted for urgent, which is the right answer, and serious after that. And indeed, sorry. Hopefully that's what I needed to do. Okay, indeed, Neisseria gonorrhea was ranked in the urgent threat category with only 4 other bacteria, showing how urgent this is, in large part because we really have very few drugs in the pipeline. So as most of you, I suspect, know, our current guidelines from 2015 for treatment of gonorrhea are ceftriaxone 250 milligrams IM plus a single oral dose of azithromycin. I think this is likely to change in the upcoming guidelines with 2 large considerations. First, antimicrobial stewardship, especially in the developing resistance and worsening resistance among gonorrhea for many classes of antibiotics, and some new information and consideration about the pharmacokinetic and pharmacodynamic properties of ceftriaxone. So azithromycin resistance has been increasing substantially over the last few years. Many of you will recall that this was added to the treatment for gonorrhea in large part with the idea that we could stem the development of resistance to either agent. Azithromycin, as shown in this national data in the upper left, has increased to about 5% overall in 2019. And local data from SURGE, which is the Gonorrhea Surveillance Project, show that about 10% of MSM with gonorrhea have azithromycin resistance. So there was an article that Lindley Barbie led published earlier that looked at azithromycin resistance development here locally in King County. And that increased, especially in the period of 2014 to 16, where it became the level of about 5% among MSM. So that continues to rise. And one sign that our single dose azithromycin in this case may be encouraging that. Another thing that we have learned a lot more about in the past few years is the PK/PD issues. And some of that comes from Dr. Barbie's research as well as others. We don't have a lot of data about ceftriaxone PK/PD in humans or how those relate to gonorrhea treatment outcomes, but we can extrapolate from a mouse model as shown here. So in that mouse model, a concentration of 5 mg per kg was required to stay above the MIC of gonorrhea. And with our current dosing, we achieve that concentration in 50 kilogram adults, but the average American adult is 80 kilograms, which means that our concentration is probably too low with the dose of 250. And we would need a higher dose, around 400 or 500, similar to treatment guidelines in other areas of the world to achieve that concentration. So I don't know exactly how the guidelines will change, but almost certainly there will be changes in gonorrhea, perhaps to increase the dose of ceftriaxone and perhaps to remove azithromycin. We will know soon. Okay, great. Let's move on to Chlamydia trachomatis and Mycoplasma genitalium. So here's a case. Please get ready for another poll. Here's a 42-year-old man with well-controlled HIV, undetectable viral load, CD4 above 500, who completed routine STI screening at his last medical visit and had what the test results shown below. Chris, do you mind going ahead and bringing up the poll? So we had rectal chlamydia with no chlamydia or gonorrhea at other sites. How would you treat him? Azithro, doxy, long doxy, or he needs to come in for more assessment? Okay, so just over half of you have voted, and looks like things are starting to slow down. So Chris, let's go ahead and end that poll. Okay, great. So the winning answer was a week of doxycycline, and the first 2 are options in the current treatment guidelines, but we'll go through some changes in that as well. And then the third option of 21 days is sometimes used with the idea that rectal chlamydia may be LGV, but that isn't necessary, and I hope I can convince you of that. All right. Let's see. Okay. So the 2015 guidelines for chlamydia treatment had both single dose azithromycin and a week of doxycycline as first options for chlamydia. There are some factors that make doxycycline a more attractive option and some factors that make azithro a more attractive option. For doxycycline, there's evidence that it may be more effective, especially for symptomatic genitourinary infections. And we now know that it is definitely more effective for rectal infections. And the poll results reflected that many of you know or would do that already. Azithromycin does continue to have the advantage of being a single dose that can be observed in clinic and is a large part of why many clinicians prefer that, especially when they have adherence concerns about doxycycline. There's also evidence that generally supports the equivalence in GU tract infections more broadly, asymptomatic and symptomatic, and it's safe in pregnancy, which is a major advantage. So what do we know about the effectiveness of doxy versus azithro in the urogenital tract for chlamydia? Well, there's some data shown here, starting with a meta-analysis from Kong in 2014 that reviewed 23 randomized controlled trials. So this really summarized the literature well before that. And what you can see is that although doxycycline, the point estimate of efficacy was slightly higher at 97 than azithro at 94, There was a very slight absolute difference, so 2.6%, something that in general we have as a field not felt, pardon me, warranted making doxycycline first line to date. In those trials, looking just at symptomatic infections across those studies, there was a greater difference in infections, so 7.4% absolute difference. Will Deisler published another randomized controlled trial in 2015 that compared the two drugs in an adolescent detention facility and found that, again, doxycycline slightly more effective, but didn't meet the pre-specified threshold for non-equivalence. And again, a signal that among symptomatic infections, there may have been a greater difference, although that wasn't statistically significant. So I think the takeaway is that doxycycline may be a little bit better, especially for symptomatic infections, but that in general, the two are quite similar in efficacy for treatment of overall GU infections. But what about rectal chlamydia? Is that different? So far, we have really extrapolated treatment guidelines for rectal chlamydia from genitourinary infections, but there are a lot of reasons to think that treatment in the rectal site is different. So we did recently complete a randomized controlled trial that I do think answered this question and looked at doxycycline versus azithromycin for the treatment of rectal chlamydia. Started with men in Seattle and Boston who had been diagnosed with rectal chlamydia through routine clinical practice. And those who entered the trial were randomized 1-to-1 to receive either azithro or doxy with matching placebo for the other, and did repeat rectal swabs at the time of entry. They then followed up at 2 weeks for another swab and adherence assessment, and at 4 weeks for another rectal swab, which was the primary endpoint of the study, whether or not the chlamydia had cleared at 4 weeks. And we ended up enrolling 185 patients rather than our initial goal of closer to 250 because the study was stopped at the midpoint on the basis of efficacy. As you can see here, participants were equally likely to discontinue treatment in the two groups. And I want to briefly describe the analysis populations for the results that I'll show you. So intention to treat includes everybody enrolled in the trial. It most clearly reflects clinical practice. The complete case population, it was restricted to participants who had a positive rectal chlamydia at the time they enrolled in the study. So everybody had had the clinical one, but some were negative by the time of repeat. And in fact, about 20% were negative by the time of repeat without treatment and had cleared spontaneously, it appears. The per protocol population were the people who did everything according to plan, including no condomless anal intercourse during the follow-up, which was the main reason for people dropping out of that group. So this slide shows the results in those two different analysis populations. First, in the complete case population, doxycycline was 100% effective and 74% effective for azithromycin. That led to an absolute difference of 26% with pretty robust confidence intervals. The intention to treat population was a little bit lower with 91% in doxycycline. And importantly, most of those were imputed failures due to lack of follow-up, and 71% effectiveness for azithromycin in the intention to treat group. Only one participant in the entire study who was randomized to doxycycline had a positive NAT at the time of follow-up. The others that were imputed as treatment failures were lost. So really doxycycline performed much, much better than azithromycin, even without adherence support, and in general, a trial that was intended to reflect real-world practice. So two questions that often come up, well, what about adherence to doxycycline and what about LGV? So first, for adherence to doxycycline, most of the participants in our study did meet the adherence threshold that we set, which was pretty generous, of at least 10 doses in 10 days. And I don't think that this is sufficient reason to give azithromycin for most patients in clinical practice, since I think that real-world adherence problems are unlikely to make up the difference in effectiveness between the two drugs. LGV was not the reason that we see a big difference between the two drugs. It was only 6% in our patient population, and there were similar outcomes in the non-LGV population, which was, of course, most of the participants. All right, so now let's switch to Mycoplasma genitalium, which, just a reminder and refresher for everybody, clearly causes urethritis in MSM. There is substantial evidence that it also causes cervicitis, PID, and associated clinical outcomes in women, although there isn't consensus in the field about that yet. The population prevalence data that we have is pretty old at this point, but even at that time, it did appear that MGen was slightly more common in the overall population than gonorrhea and less common than chlamydia. It's essentially in between the two. We do now have an FDA-approved test for Mycoplasma genitalium that is from Hologic, the Aptima test that runs with the same platform as the gonorrhea and chlamydia testing that's done on the Aptima Combo 2. However, there aren't yet any formal recommendations for screening. That may or may not change with the next set of guidelines. And we do have some recently updated clinical epi data about MGen that I'd like to share with you today. So the MAGNUM study was completed and just published earlier this year, and this was a multi-site study of men with urethritis seen in sexual health clinics. And one of the first things that was done was just looking at the pathogens among men with urethritis. And what you can see is that Mycoplasma genitalium accounted for just a little bit more than chlamydia in those cases, 29% overall and 29% for us here locally in Seattle. When we looked at, or rather the investigators looked at resistance mutations, there are some concerning findings. So first, for azithromycin resistance, there's a 23S rRNA mutation that pretty clearly confers resistance to azithromycin and is tied to clinical outcomes. And what you can see is that was present in 64% of the MGen isolates overall. And here in Seattle, it was 76%, so 3/4 resistant to azithromycin. Quinolone resistance is a little bit more difficult. This did look for the PARC mutation, which doesn't necessarily confer clinical resistance to quinolone in MGen. It's a little less straightforward, but does still, I think, serve as a harbinger of problems to come with 12% PARC mutations, which could confer quinolone resistance. This is particularly problematic because we don't really have any agents after quinolones in terms of treating Mycoplasma genitalium. We've had a few isolates that are quinolone resistant here, and they are extremely difficult to treat. So in response to this and some of the data I showed you earlier, thinking about our use of azithromycin and doxycycline for urethritis, our colleagues in Australia at the Melbourne Sexual Health Centre published their results of a treatment algorithm a few years ago that they were using in Melbourne, which pretty quickly made its way into treatment guidelines in many other parts of the world, though not at least yet in the US. So the way that works in their clinic is that patients with urethritis, cervicitis, or proctitis first receive 7 days of doxycycline. And all of those patients also get an MGen test that is a combined diagnostic and resistance assay, something we don't have here in the US available clinically. For patients who are MGen positive, they are then treated depending on the susceptibility results. If susceptible, they get azithromycin, though still not single dose, a prolonged course over 4 days. And if azithromycin resistant, at least initially, they got a quinolone called citalfloxacin. That's not something available in the United States. And when this group first published the results of this clinical algorithm, they reported pretty high cure rates with 95% in the susceptible group, 92% in the resistant group. And they recently looked at a prospective evaluation of patients in their clinic using a similar, really the same algorithm, but with moxifloxacin instead of citalfloxacin, something we do have available here. So these results just published earlier this year in CID looked at nearly 400 patients with MGen, all again treated upfront with doxycycline 7 days, then depending on their susceptibility. And they found, again, really the same 95% cure, 92% cure in the two groups. So I think that is, again, more evidence to support this approach. So here is a proposed approach to urethritis treatment in the US based on that. And I just want to be clear, this isn't recommended in the CDC guidelines, at least the 2015 version. It is what we use in the sexual health clinic, formerly the STD clinic here in Seattle. So when a patient comes in with urethritis, has symptoms, the first thing that is done is a gram stain of the discharge. This can be done point of care in the sexual health clinic. I recognize that is not possible in many other clinics. If a patient has gram-negative intracellular diplococci, they're treated for gonorrhea and other pathogens, since at this point we don't know the cause of their urethritis, with ceftriaxone and doxycycline. If they do not have gonorrhea apparent on gram stain, they get a week of doxycycline, they get MGen testing, and then if positive, they are treated with moxifloxacin. So since we know that most of the isolates here are already, we know that most of the isolates are resistant to macrolide, we don't have that assay, nor really, frankly, the need to look at that. So we do just treat MGen with 7 days of moxifloxacin. A question that often arises if you get that result while the patient's still taking the 7 days of doxy, should you continue the doxy? And in fact, yes, that is what we're doing. There is some data to support the idea that doxycycline decreases the bacterial load of MGen, even though it isn't an effective treatment in and of itself. So the sequential treatment does, maybe, we think, work better. Okay, so bringing you back to attention and a new poll, which is really just trivia, because this isn't apropos of anything. I just learned it while putting together this talk and thought it was interesting. So this sexually transmitted pathogen is itself frequently infected with a virus: Chlamydia, gonorrhea, Mycoplasma genitalium, Trich, Shigella, or T. pallidum. Great, thank you all for voting. It is exciting to see these coming in, and I want to make sure I'm sharing the poll correctly. I'm not sure I shared the last few. Okay, so let's end the polling. Nope, sorry. Oh dear. Okay. Okay, so you can now see the poll results. And the most common answer, though not the majority, was the correct one, Trichomonas vaginalis. At least to my knowledge, none of the other pathogens are frequently infected with a virus, but there may be something else I don't know. So, Trichomonas. In fact, there is a virus called Trichomonas vaginalis virus. It is a double-stranded RNA virus. And at least in the studies, most of which have come from, that I've seen from the southern US, it's around 40% of trich that's infected with this virus. It's there, it's interesting. It doesn't seem, at least yet, to be related to anything to do with antibiotic resistance or clinical outcomes. So it is really just sort of an interesting fact. Okay. So speaking of Trichomonas vaginalis, let's review the treatment guidelines there. For this one, I think that most of you know this, but really want to point out that the 2015 guidelines are substantially outdated at this point. And the ACOG guidelines released this year do have the recommendation that I think is most likely what the CDC will recommend with the next iteration of the guidelines, which is instead of single dose metronidazole or tinidazole, a 7-day course of 500 milligrams BID. We have large, well-conducted randomized controlled trials now showing superiority of the week-long course in both HIV-positive women and HIV-negative women, with the percentages that you can see there. Another point that I just want to make, this again isn't really new information about trich treatment, but is that we often are concerned about the disulfiram-like reaction with metronidazole and alcohol. And in fact, that is something we need to let go of. It was initially thought of as an idea with the wrong understanding of the chemical structure of metronidazole, and in fact doesn't really have any data to support that reaction. So I think that will probably come out of the guidelines. I just want to mention this in part because I myself have had patients who have had trich and then have come back not taking treatment because they were concerned about this alcohol reaction. So it's been perpetuated through our medical, nursing, pharmacy education, but it really is something that should not prevent us from using metronidazole to treat women who drink alcohol with trichomonas or bacterial vaginosis. Okay, back to trich. Again, there's not a lot of robust treatment research on this organism for many reasons, but it does come up a lot clinically through our PTC and in the sexual health clinic. So I do want to briefly just describe alternative treatments and give you a resource if this comes up for you. So the first line treatment for alternates depends on the reason that you're giving alternate treatment. If it is because of metronidazole resistance, that's the only class of drugs that's effective against trich. So we use higher doses and longer courses and try again. And those are shown there and are in the guidelines. One of the many problems is that intravaginal tinidazole and oral tinidazole is quite expensive and not within reach for many of our patients. For patients who have metronidazole allergies, there are oral desensitization protocols, and consulting an allergist can certainly be helpful and is recommended, but again, is another thing that just isn't available in a practical sense to many of our patients. So all of the alternatives for trich treatment have poor quality evidence to support them. None of them are great, and we can't usually use any intravaginal treatments in pregnancy. But again, this is something that, at least in my experience, we do end up needing to use. Intravaginal boric acid is available at compound pharmacies and over the counter. A little bit harder. Intravaginal peromomycin cream is an option. And then betadine douches, something that Laura Reichel in the sexual health clinic treated a patient with this year. So that involves betadine that we have in our clinic and soaking tampons and putting them in overnight. So just want people to be aware of this resource. If you have questions, please feel free to consider the PTC consult line, but want to just briefly drop that in. Okay, so that is summarizing the treatment changes, the longest portion of this talk. The others will be shorter. Let's switch now to the context of COVID-19. And now get ready, please, to take a poll again. So let's now imagine it's January of 2021, and King County is back to phase 1 of our reopening plan, which means that clinical services are limited, a place that we were several months ago. Your patient calls to let you know that they've been exposed to gonorrhea. Patient told them they had gonorrhea. So you now have a patient who has contacted gonorrhea. What do you recommend? Deferring treatment and coming back in? If symptoms develop, screening later, the usual treatment of ceftriaxone, which requires some kind of in-person visit, or Syphilis and ceftriaxone as shown there. Oh my gosh, sorry, we have the wrong poll up. Sorry, okay. Chris, is there a way to switch to the other poll? Maybe we should just finish the polling for this one, which is next.
I'm sorry, Julie, I only had 4.
Oh, okay, no problem. No problem. So I'm trying to think about how to, okay, I'm noticing for the next poll, the distributions, which we didn't read out loud. I'm gonna go ahead and close this poll and put it down. Sorry about that, Chris. That was probably my mistake in communicating. So think to yourself, what would you use? Okay. All right, well here I want to, again, not go into great detail, but mainly give you a resource, because right now we aren't in the position described back in phase 1, but we could, this varies throughout the region, and we could very well be there again in a few months. So Lindley Barbie and others published a great paper with local recommendations for alternate oral treatments. And I'm showing you one of the tables from the paper here. And as you can see, for the patient we just discussed, a gonorrhea contact, 2 of the recommended regimens as alternates for oral, if the drugs are available, are cefixime 800 milligrams plus azithro, or cefpodoxime 400 milligrams twice plus azithro. So none of these are standard regimens, and they're not the preferred, but nothing about COVID is really preferred. So this is the best that we can do in the circumstances we have. Again, not where we are right now, which is to the most part back to restoration of clinical services, at least here in Seattle. And CDC did write a Dear Colleague letter talking about how to prioritize clinical services as well. That paper also does recommend syndromic treatment, which is another option. We may have patients, if we're under a severe lockdown again, who aren't able to get diagnostic testing, and we may be left treating syndromically. There's a table again in this paper that makes some recommendations that I hope you will reference if needed in the future. Okay, so what is happening with STDs in COVID? We have some preliminary information. I don't think we know for sure what's going to happen during COVID and after COVID. So without doubt, case reporting is down, and this is due to a combination of probably changes in sexual behavior, reduced clinical services and reduced testing, and also massively reduced public health resources. And public health are the ones who take these case reports and enter them and process the data. And most of our public health epidemiology effort right now is dedicated toward COVID-19. So that said, this was shown in a talk at the STD Prevention Conference. CDC numbers, which you can see for all 3 of the major bacterial reportable STDs, drop off pretty substantially during March and have started to come back up over subsequent months. This slide shows what we've seen with case reports so far in King County for 2020 versus 2019. And these are some graphs taken from a great talk that Roxanne Karani gave as a late breaker at the conference. And what you can see are the 3 separate periods, at least corresponding to what happened here in Washington State, with pre-lockdown, the stay home order, and reopening. 2020 is in red, and what you can see is it definitely dips below, especially during the stay home period, and then recovers a little bit with reopening. Overall, 13% decrease in gonorrhea. And in weekly syphilis cases, there was a sort of similar pattern with an 11% decrease. So some decrease seen here locally as well. So how much of this is because people are changing their sexual behavior? Many of the people listening to this see patients, talk with clients, and I think we've probably noted that there are really heterogeneous patterns of sexual behavior under COVID-19. One piece of data we have is from a longstanding internet survey among MSM in the United States called the American Men's Internet Survey from a group at Emory. And they published some data on sexual behavior pretty early in the epidemic. So certainly this may have changed, but in April of 2020, with about 1,000 participants on their internet survey, they did in fact see that just over half of MSM in that survey, with whatever its limitations are, had decreased their sexual behavior, and very few reported increasing sexual behavior at that time, really vanishingly few. In general, decreased opportunities to have sex, and in general, roughly half had also decreased the use of dating and hookup apps, at least to meet in person. In terms of behavior and sex and what we recommend to our patients, we have put out a King County fact sheet in part, or not rather a fact sheet, but some local recommendations for sex under COVID-19 for MSM. And this was inspired by the New York City guidance that was really excellent, and we put together with some input from community representatives here. So that essentially tries to differentiate really safest sex from safer yellow and avoid behaviors in red. And so that is available at the link shown below, or if you just search King County COVID sex, you'll be able to find that information. Okay, another thing happening under COVID, as many of you are aware, is a shortage in the swabs that we use for nucleic acid amplification testing. And this impacts a number of testing platforms and diagnostic tests, and I know is certainly starting to affect a number of clinics. So there is a CDC Dear Colleague letter that I think is really quite helpful in terms of thinking about how to prioritize under a swabs shortage. Their key recommendations are shown here. So prioritize women who are under 25 or at risk for chlamydia and gonorrhea, as well as asymptomatic MSM. And in MSM, prioritize extragenital screening, and they recommend rectal more than pharyngeal, more than, again, genitourinary screening. Also, consideration for extending the screening intervals beyond every 3 months, and that is a key part of the approach that Madison is going to take to respond to this. Empiric treatment of patients with STI syndromes. So usually we would empirically treat and test, can consider foregoing testing and foregoing testing of contacts, though still they should be treated empirically. Okay, another thing happening in the COVID-19 context is home self-testing. There are some commercial labs that have been doing home self-testing even prior to COVID, shown here, not endorsing any of these by any means, but just noting that they're here, and it is an option for patients, and many patients are using them. CDC did specifically name molecular testing labs, again, didn't endorse it, but in talking about home testing, did name that as one of the labs, for whatever that's worth. There's also some interesting research on home HIV STI testing. Certainly the swabs for gonorrhea and chlamydia are pretty straightforward. We know for sure those can be done at home, self-collection equal to clinician collection, stable and sent in the mail. But the hard part is HIV for those who are HIV negative, and syphilis testing. And so there are some interesting approaches to this, including a study being led by Chase Cannon in the public health Seattle and King County Sexual Health Clinic that's going to launch soon. And that will take patients on PrEP and offer them home testing, including with a new device, to an investigational device that can collect a small amount of blood for specifically for RPR testing and for HIV testing. So we'll be excited to see what Chase learns from that study. It has so far seemed acceptable to patients and they are interested. At the STD conference, there was at least one experience with home testing reported. This is a little bit different than clinical context, but Emory CFAR does provide home testing web-based for research studies throughout the country, so research context. And they did have a lot of requests and find some cases, but one of the most concerning things they reported was very low return rates of the kits, so 25%. And when they did some qualitative research, found that some of it was just curiosity, that essentially men said, well, I was just curious, that they weren't ever really intending to test. And then patient lack of confidence, that once they saw the materials and the instructions, they just did not feel confident that they could collect specimens appropriately. I think that's going to be different in Seattle and our patients on PrEP, but we will find out soon. Okay, so this is the poll that many of you were answering. And Chris, is it possible to bring that poll back up? It is, thank you. Okay, so now nationwide, the relative increase, in incidence rates from 2014 to 18 was greatest for which of the following infections? And I can see you're voting, thank you. Chlamydia, gonorrhea, syphilis, primary and secondary, or syphilis congenital. We're getting very high participation in this one, which is great. And interestingly, the results look a little differently than when it was put up the first time. Okay. Okay, great. So 48% of people got the right answer, which is congenital syphilis. And of course, the greatest increase in congenital syphilis, the greatest relative increase is in congenital syphilis because it started from a period of near elimination, approaching elimination at the beginning of that time period. But all of the others have certainly increased substantially. Okay, so here's just a reminder where you can actually see those percent increases over that 5-year period. 20% increase in chlamydia, which has historically been high and increasing year after year. 63% in gonorrhea, going up from relatively historic lows, 71% in syphilis, and 185. Now, actually probably higher with some slides that Gail Bullen showed last week. So congenital syphilis. I just want to briefly make everybody here aware of the epidemiology, both nationally and what's happening in King County. I recognize that many of the people on this call may not see a lot of pregnant women or women with syphilis, but something really important for all of us to be aware of since it is a devastating public health problem. So this is from the 2019 report, STD Epidemiology report, which really shows that year after year increasing congenital syphilis through 2018. And then Gail Bullen showed us some slides at the STD and AIDS research conference a couple of weeks ago that showed some preliminary data from 2019 where the rate is closer to 9 per 100,000. So really continuing to increase. Nationally, syphilis among women seems to be driven in large part by injection drug use and the opioid epidemic and the meth use epidemic. There are some graphics shown on this slide taken from an MMWR report that really looked at how injection drug use, meth use, heroin use has increased substantially among women and men who have sex with women who are diagnosed with syphilis. So it really is hitting a very marginalized population. And many of the women who end up having babies with congenital syphilis don't access prenatal care, at least nationally, around 1/3 of the women. So let's switch to King County where things look a little bit different and want to just give you the latest information available. So Anna Burskalms presented an excellent talk on congenital syphilis at the conference, and this is the slide from her talk, which shows syphilis among women increasing through 2019 here in King County, a similar kind of trajectory to what you see nationally. We had 3 cases of congenital syphilis at the time that she gave this talk. The update is now 4 cases of congenital syphilis since June of 2019. Interestingly, all of the women that gave birth to those babies had been in prenatal care. So again, in the small group, different than national trends, all had negative first trimester screening. So one recommendation is, so these were women who acquired syphilis during pregnancy, and one key recommendation that isn't yet in the guidelines may be, but is for clinicians to consider third trimester screening with an RPR at the same time, the 28-week, as the glucose test is done to screen for gestational diabetes. So something to please consider. Okay, now let's switch to the last section, advances in prevention. I'm going to talk about doxycycline prophylaxis, mouthwash, and meningococcal B vaccine. Okay, so doxycycline prophylaxis for STIs, something that I think most of you are probably at least somewhat familiar with. We have 2 studies looking at doxycycline PrEP and PEP in relatively small groups, summarized here. Bob Bolin and colleagues in Los Angeles did a study with 30 HIV positive MSM with a history of syphilis who took either half dose of doxy daily or contingency management, where they were paid cash for having negative STD tests. And they found that the doxy group had a 73% decrease in STIs, and that was statistically significant, which they didn't expect in this initial trial. That was really driven by decreases in syphilis. And in this small group, no self-reported behavior change. Molina and colleagues published a study in Lancet Infectious Diseases a few years ago that looked at HIV negative MSM who were on event-driven HIV PrEP in France and added on doxycycline PEP, or post-exposure prophylaxis, which is a full dose of doxy taken, excuse me, I think I said that the wrong way, pardon me, a double dose of doxy taken within 24 hours, but up to 72 hours after sex. And this found a 47% decrease in combined STIs, again, with the largest decrease, around 70% in chlamydia and syphilis, no decrease in gonorrhea. In France, most Neisseria gonorrhea does have resistance to tetracycline, which is different than in the United States. So a lot of unknowns and a lot of current studies I'll review in just a moment. What do we know about patient interest or client interest in doxycycline for STI PrEP or PEP? We don't have a lot of information yet, but what information is available suggests very high levels of interest. On the left, you can see a Grindr survey that was done in multiple cities of the US, which found that HIV negative MSM, 84% said they were interested in doxy PEP, and HIV positive, 86% of men. And interestingly and encouragingly, African American and Latino MSM were more likely to report interest. This does, of course, again, have all the limitations of a survey on Grindr. In our STD clinic, we did our PrEP program. We did just a brief survey prior to launching the doxy PEP trial to ask patients on PrEP whether or not they would be interested in doxy PEP after explaining to them what it was. 90% said they would be interested. So don't know yet how this will translate into use, if it is in fact effective and safe, but some signals that patients are really interested in this. We asked about doxycycline prophylaxis use among men and transgender persons who have sex with men in our annual Pride survey in 2019. We weren't able to do that fully and in the same way again this year. But this is an annual survey to Pride attendees. And we introduced the idea of doxycycline prophylaxis, either post or pre, and then asked participants, have you ever taken doxycycline to reduce the risk of getting an STD? So with that, 9%, which I'm sorry isn't showing up on the slide, 9% said that they had, and that was roughly evenly split between PrEP and PEP. So that is in 2019. And although it's not a huge amount, I would say is certainly interesting that patients are already taking this, some in the community, if they understood the question correctly. It really differed the way you would expect by HIV and PrEP use status, with really most of the use in HIV negative persons who were on PrEP. So 21% said they had used doxycycline, much higher than we would have expected. It would help to see that year after year. All right, a lot of ongoing doxycycline prophylaxis studies, including the doxy PEP study here in Seattle and in San Francisco, led by Connie Kellum and Amy Lukemeyer. That's an open label RCT of doxy PEP and is recruiting MSM and transgender women living with HIV or on PrEP. And the outcomes of that are STI incidence, safety, antimicrobial resistance, and acceptability. It might look different using PEP for patients who are on daily PrEP. We will get some great information from that study. Another UW study is in Kenya with young women. A study from the Molina group in France is another large open label RCT. Those are all PEP studies. And there are 2 PrEP studies, smaller and single arm, looking at daily doxycycline. So it will be exciting to get some information to hopefully help guide us about especially the safety and the true effectiveness of this approach. Just a quick plug for the Doxy PEP study in Seattle, especially those of you who are in Madison Clinic or the Sexual Health Clinic. For patients who are on PrEP in Sexual Health Clinic or HIV positive in Madison, we are very interested in enrolling participants in this study if they're MSM or trans women who have had a bacterial STD in the past year. Referral information there. Please feel free to reach out to any of us. Okay, so that could be helpful, DoxyPEP for chlamydia and syphilis in particular, and perhaps for gonorrhea. What other interventions do we have for gonorrhea prevention? Well, sorry, again, the animation on this slide isn't working quite well, but one interesting study that was reported at the STD Prevention Conference from colleagues in Australia was the Omega study, oral mouthwash used to eradicate gonorrhea. So this was the idea that pharyngeal gonorrhea we know is common among MSM and contributes to ongoing transmission. What if something as simple as daily mouthwash would prevent that? That would be really exciting and likely quite cost effective and acceptable. So they did a double-blind randomized controlled trial, enrolled just over 500 men in the sexual health clinic, and looked at the primary outcome of pharyngeal GC-NAT positivity within 12 weeks. And unfortunately, there wasn't a significant difference. So Listerine, which was the intervention, and biotin, which was an inert control that patients did a mouthwash with, not significantly different, with an absolute of 2.5%. So that was disappointing, not entirely surprising, I think. Very exciting, and hopefully we will get some new information. Well, actually, I don't know exactly when the trials will end, but very exciting. Do we already have a partially effective gonococcal vaccine? So the Neisseria gonorrhea is very closely related to Neisseria meningitidis, and especially for serogroup B, Neisseria meningitidis, and vaccines against that serogroup, there is some cross-reactivity between Neisseria meningitidis and Neisseria gonorrhea with the outer membrane vesicles. So that gives us the idea, or gave people the idea, that perhaps meningococcal vaccine could have some effect on preventing gonorrhea infections. And initially there was some ecological evidence in Cuba and Norway that basically said, hey, look, after we did the vaccines, there was a dip in gonorrhea. So interesting, but ecological evidence. Now there have been some interesting case control studies in a number of places, including starting in New Zealand, where they gave essentially a mass meningococcal vaccine campaign in response to an emergency outbreak. And then these investigators did an excellent study where they looked at sexual health clinic participants who got vaccine or didn't get vaccine, and chlamydia and gonorrhea cases. So the chlamydia cases were the controls. And what they found was that patients who had been vaccinated were substantially more likely to have received the meningococcal vaccine. So that led to an adjusted estimate of 31% efficacy of the vaccine. And you can see in the left the dip in gonorrhea cases that occurred with no similar dip in chlamydia cases on the right. At the most recent conference, New York City and Philadelphia reported a very similar case control study with an estimated 41% efficacy. So we still don't know if this is efficacious. There is an ongoing randomized controlled trial in Alabama and North Carolina testing the Bexsero vaccine for gonorrhea prevention that will give us that answer, hopefully. And we still don't know the public health impact of the vaccine. So this depends in part of duration of immunity, which does probably wane, often estimated anywhere between 6 months and a few years, and uptake in the population. Will it be acceptable? Something we often struggle with in the US. But with a partially effective vaccine and even with incomplete uptake, this could have a substantial impact on gonorrhea cases. Okay, so synthesis of this talk, and I'm going back here to the learning objectives, which I didn't review in the beginning, but did put forth for this talk. So single dose azithromycin is really falling out of favor for STD treatment. We really need to continue to question this. It fosters resistance to azithro in Neisseria gonorrhea. It's probably less effective for chlamydia, especially for rectal, we know, and probably for symptomatic GU cases. And most M. genitalium are already resistant, and use of that may drive that resistance up even further. There are treatment options that are oral only for most cases of STDs in the context of the COVID pandemic. There's the great paper that Lindley led that I referred you to, which is an excellent reference. And we talked about M. genitalium, the clinical significance of that and appropriate treatment for that. It'll be really interesting to see what the guidelines say. There is an available test. We don't yet have a screening recommendation, and the drug resistance really causes a conundrum. But consider the two-stage doxy then moxy approach to symptomatic urethritis. Okay. Great, so I'd like to acknowledge my many colleagues who helped me putting these slides together. Thank you so much for your feedback and guidance, and acknowledge the Mountain West AETC. And now I would love to turn to some discussion and Q&A time. Thank you so much.
Great, thank you, Dr. Dombrowski. We've got quite a few questions and some comments as well. First question. Does PrEP make it easier to get STDs, especially syphilis, by changing immune response?
The answer to that is no. This did come up because STI rates went up so much as PrEP was rolling out. There was briefly put forth the idea that PrEP could actually biologically make somebody more susceptible to syphilis. And that doesn't seem to be the case. And there have been some follow-up studies after that idea was first put forth that really show in the initial PrEP studies and randomized controlled trials that there was really no evidence to support that idea. So no.
Okay, next question. If we at our clinic are not short on swabs, should we still decrease? Also, would you space out testing intervals for patients on PrEP or continue 3 months, Q 3 months?
Yeah, this is a great question. And I would just say there is no right answer. And I think every clinic needs to, there's no right answer. So I think first, the first part was, if you don't have a swab shortage yet, should you change? And I think sort of try to accumulate the swabs and stem the shortage. I don't know. Ideally, whoever is the source of your swabs, whether it's the lab or a direct source, you would ask them if they are seeing this and seeing them this forthcoming. I think in general, I would say that I would probably not change practices until you actually encounter a swab shortage. I realize other people may have a difference in opinion. PrEP, yes, clear recommendations for Q3 month screening, but I think that falls into the same consideration as asymptomatic MSM and women who need screening, which is that we have the option of either spacing out the intervals or changing which tests we do. So I think some key options to consider are: one, not doing urethral testing in patients who are not symptomatic. I realize that doesn't involve a swab, but there are also shortages of the reagents apparently at the lab. And I do think spacing out to Q6 months is probably appropriate. It's not ideal because when we space out to Q6 months, patients will space it out often further just by real world practice. But I would say that in general, Q6 month screening is an appropriate response to the shortage. And I would wait till you actually have a shortage to do that personally. Thanks.
Okay, next question. You mentioned 6% of your rectal chlamydia study population had LGV. Did that have any implications for treatment outcomes in either treatment group? Isn't 6% a surprisingly high number?
Yeah, great question. Thank you to whoever asked that. So first, did it have we didn't learn anything about treatment outcomes with LGV because it was still a relatively small number. It was just 8 isolates overall. And with that small number, I think all that we can really say is LGV isn't the reason why doxy is better than azithro for the treatment of rectal chlamydia. It's not that we're underdiagnosing LGV. I don't think we can say much about the efficacy of the two treatments for LGV, unfortunately. I wish we could. And 6%, I think, is around what we had some guesses of this, especially because New York City and San Francisco, who do surveillance, had reported much higher rates, actually, but that was often in symptomatic patients. So I actually thought it might be a little higher than 6%. Others had guessed around 5%. So I think that is pretty much what we're seeing. And sorry, key thing is patients in this study did not have clinical proctitis. So they were mostly asymptomatic or had mild symptoms like itching, some pain or discharge, not usually discharge, so not frank proctitis, mostly itching or some discomfort. Thank you.
Okay, next question. How about extension of expiration dates of NAAT kits? Can the medium be extended? Also, if there are swab shortages, sometimes the kits have swabs that are good much longer than the medium, but the kit itself has the expiration of the medium.
God, this is such a great question for somebody who has more expertise in this, especially in the regulatory aspects, because I don't know the answer. I would invite somebody to put the thoughts in the box. My thought is a little bit arbitrary, and especially swabs themselves don't expire, but we need to have the swabs and the media match up. And I basically don't know from a regulatory standpoint whether we could use expired kits, but it's a great option if you've got a lot of them to look into. So again, if anyone knows if we can do that without incurring regulatory difficulties, I'd love to hear it.
I think what we can do, we can type up these questions and answer them, and then we can send out the responses to the list afterwards. Another question I received, I received a lot of calls from OB clinics, including outlying UW clinics, because of positive syphilis IgG with a negative TPPA and non-reactive quantitative RPR in pregnant women. And this is pretty much consistent in most clinics. Should they stop doing the IgG because it seems to be confusing them?
Oh, such a great question. So yes, we definitely know that that pattern that you described, which is a false positive IgG or EIA, because the RPR is negative, the TPPA is negative. So false positive, we know that that is common, pretty common in pregnant women. And that if you retest those women, a substantial portion, I can't remember offhand, will actually revert to EIA negative. So there are a ton of false positives. Yes, it would be better to do RPR first. This is really a lab issue. So the switch to the reverse sequence algorithm was really for efficiency and cost at the labs. It is much, much easier to do the EIAs at the lab, an automated test, than to do RPRs. So not for a public health or clinical perspective. In other words, yes, from my standpoint, it would be better to do RPRs, but I think that is probably not an option with your lab. And so we'll probably require ongoing education and reassurance of the GYNs and their patients. Thanks for bringing that up.
Okay, so we're coming up to time. Let's do one more question, and then the rest, I can forward them to you, Dr. Dombrowski, afterwards. Okay. As I understand it, there may be a change to Cef plus Doxy to treat gonorrhea. If so, are there concerns for promoting GC resistance to Doxy if we start using it for Doxy PEP prep?
Yes, so I think I'm mostly going to take the second part, which is essentially if we're using more doxycycline, is there is there a problem with promoting resistance, especially now that we're also giving patients Doxy PEP and PrEP? I hope I rephrased that somewhat correctly. So it's interesting. The concerns for doxycycline resistant are somewhat different among the STD pathogens, bacterial pathogens, than among other microbiota, including staph in the body, where I think we really don't know what doxycycline PEP and PrEP are going to do to enterics and to staph, and is part of what the Doxy PEP study is looking at. There is no doxy resistance or resistance at all among chlamydia. There is none among syphilis yet. That could always occur. And doxycycline or tetracycline resistance is already pretty common among Neisseria gonorrhea. So I'm sorry, I don't remember the numbers offhand here locally. So broader use of doxy could drive that up in gonorrhea, but we don't use doxy for gonorrhea treatment now. anyway. So interesting question and focus for study. Thank you.
All right, so we are at 9 a.m. I just want to thank Dr. Dombrowski for being our speaker for this month's AIDS Clinical Conference. Thank you again, Dr. Dombrowski. And an invitation to everybody. We hope to see you in next month's AIDS Clinical Conference in November, which will be our annual art update with Dr. Brian Wood. And please be on the lookout for the information on how to access the evaluation for today's session. So again, if you have any additional questions, any additional comments that you would like to share, please email them either to Amber Tejada, which the email came in your confirmation email to this event, or to me, which I sent out an email to everybody yesterday. Again, thank you to everybody, and we hope to see you online next month in November.